Okay, let me kill this for a second, the video, just so you can see the picture. But hi, welcome to another Rush Generations Health Education Lectures. Rush Generations and our staff, as always, is delighted to be your source of information, resources, and health promotion programs that help maximize your well-being and good health as you age. Today is Wednesday, November 5th, and I'll be your moderator. I'm Grisel Rodriguez Morales, Rush Generations Program Director, and today's lecture is titled Understanding and Managing Diabetes. Before I present to you the wonderful speaker who is joining us today, I'd like to first thank our producer, Hannah Weitzman. Hannah will be helping us manage the chat and other key aspects so that we can all have a great conversation about diabetes, including causes, risk factors, and management. As always, we're live streaming this lecture via our YouTube channel using the video platform Zoom, which also allows us to host a good number of people who join us via phone. Thank you for joining us. For those of you on YouTube, we ask that you please use the chat function to ask questions and or to add to the discussion throughout the lecture. We will make sure that your comments and your questions make it to today's presenter. And for those of you listening to the discussion via phone, you know the drill. You will also have an opportunity at the end of the presentation to unmute your audio so that you can ask your questions. Of course, we like to remind you that all the information offered here is for general informational purposes only. And we want you to always seek additional professional advice for situations that are very specific to you and your needs. Okay, so today we have with us one of our dear Rush University Medical Center colleagues, Dr. Mario Campaña, who is an endocrinologist originally from Ecuador. He completed his residency in internal medicine at St. Barnabas Hospital in New York, and then completed a fellowship in endocrinology at the University of Alabama. Dr. Campaña has also a certification in obesity medicine. His professional interests and passions include obesity and weight loss management, sports medicine, lifestyle medicine, diabetes, polycystic ovary syndrome, and metabolic dysfunction associated liver disease, or AIMS, AMSLAD. Sorry, you will say it better than me. So, Dr. Campaña, welcome. Thank you for joining us.
Hi, thank you so much. Thank you so much for the invitation. I'm happy to be here and share a little bit about the real pandemic that is diabetes. So I just gonna share my presentation so we can start it. I think everybody's able to see my...
Yes, this is great.
My PowerPoint. Okay, so let's start. So talking about diabetes, this a couple of topics that we want to discuss here. I will say the most important part is at the end, that is how lifestyle change can help with preventing diabetes, managing pre-diabetes, that is in a stage that you don't have diabetes, but still you have abnormal amount of sugars in your body and you have predisposition to diabetes, and finally diabetes. So to start, we need to define what is exactly diabetes. And I think diabetes is not like a single disease. It's not a single illness. That's what we need to understand. When you hear the word diabetes, everybody thinks that it's just one condition that affects multiple things, but it's not just one condition. It's a group of many metabolic conditions or disorders that at the end, the results of uncontrolled metabolic conditions is the diabetes. So if you see, there is a different way to define a collective metabolic disorders that can cause high blood sugars, a group of metabolic disorders that affect the carbohydrate and cause high blood sugars, a combine of metabolic conditions that disturb the insulin secretion or the insulin effect or both and cause hyperglycemia. Insulin basically is that hormone that is produced from in the pancreas that is basically the hormone that takes all the sugars that we eat during the day and then process and convert to energy. That's what insulin does. Or an uncontrolled high blood sugars after all these metabolic conditions that over time can cause some serious damage in different type of systems, vessels, or nerves. So this is my definition of diabetes. So it's a combination of chronic metabolic condition that affect the secretion, the utilization, or both of this hormone insulin, that is the one that is producing in the pancreas, that is in charge of take all the sugar in our body and use to make energy. And this cause a high blood sugars that with time can affect your vessels, nerves, organ, including your mental health, because this is a chronic condition that you need to monitor and manage forever. And of course, that can affect your mental health, causing anxiety, depression, and also affecting your daily living activities. So that's the definition of diabetes. It's a big group of metabolic conditions that ended up affecting the production, the utilization, or both of insulin. So, what are the risk factors of diabetes? So, diabetes, as we said, is a combination of multiple metabolic conditions, but is also uh, multiple factors affect these conditions. So we can talk about the socio-demographic factors that can be age. Aging is a factor, especially uh, adults older than 65 have more predisposition of developing diabetes. There is a highest prevalence of diabetes in this age. Sex, usually men have a slightly higher prevalence of diabetes, but also women have a higher prevalence of undiagnosed diabetes. So age, sex is a factor, race, and ethnicity. So based on this study from the nutritional health system, 17.6% is most likely Hispanic. So this is a condition that have more predisposition on the Hispanic population. Also, the next one would be African American or Black population, and then Asians and white. But that's very important because this is the population that we need to be a little more aggressive on our screening and be aware that just being an Hispanic or an African American can increase the risk of developing diabetes. And a socioeconomic status, of course, lower socioeconomic status can have a big impact on developing diabetes because there is poor access to screenings, poor access to medical attention. So yeah, a socioeconomic status effect. Talking about the clinical factors, family history. So if in your family, you have both parents, you have brothers, you have sisters, grandparents that have diabetes, you have like at least 2 to 3 fold increased risk of developing diabetes. So that means that you need to be more aware of this and do it and be more aware of your screening tools to make sure that you are not developing diabetes, or if you're a pre-diabetic, you can start working on some lifestyle changes to prevent diabetes. Or even if you didn't be hasn't been diagnosed with diabetes, all also work on your lifestyle to prevent pre-diabetes or diabetes. So family history is very important. We talk about a lot of metabolic conditions. So what exactly are these metabolic conditions? So let's start with obesity. Obesity, it's one of the biggest risks for developing diabetes, high blood pressure, cardiovascular conditions like heart failure or previous heart attack, sleep apnea, polycystic ovarian syndrome, and metabolic syndrome. That is a quick combination of some of these conditions. So that's what we call metabolic conditions. So all these metabolic conditions had also an important predisposition to develop diabetes. And finally, the lifestyle factors, diet. Of course, diet is very important. Red meat, processed foods, sugary drinks, of course, are associated with type 2 diabetes. Physical activity. So all patients with sedentary lifestyle with more predisposition to weight gain, this is a factor that increases the risk of type 2 diabetes. And I want to highlight this important comment, like physical inactivity. Even if you are not gaining weight, even if you are not obese, even if you are not overweight, but just not being active still increase the risk of type 2 diabetes. So that's why exercise needs to be part of your life forever until the end of the days. And I will let you know exactly what I mean with physical activity, because many people think that, oh, physical activity is going to the gym, have my 1 year subscription, start a treadmill for 60 minutes every day. No, that's not the only way to have physical activity. I'm gonna give you a couple of options, realistic options that helps to be more active and prevent diabetes, or if you have already diabetes, to help with the diabetes. Smoking and alcohol, of course, these two are big factors for a lot of conditions, not just diabetes. And of course, they're on the list, have more predisposition to diabetes. Vitamin D deficiency and poor sleep duration. So that two things, still there is not, even after multiple studies, there is not like a clear correlation of vitamin D deficiency or poor sleeping with diabetes, but we know that poor sleeping is a risk factor for gaining weight. So still, even if it's not a clear correlation, I still recommend to have a good amount of vitamin D and also have a good sleep hygiene. So in this picture, I'm just showing all these factors combined, and I divided in factors that you can modify and factors that you cannot. We cannot modify our genetics. We cannot modify our family background. We cannot able to modify family history or our race or ethnicity or aging. We're not able to modify aging. So that those factors are the factors that there is out of our hands. We're not able to modify those. But the other factors, physical activity, of course, we can modify that. Work in our weight. Again, we're gonna talk about weight loss. That weight loss is not all the thing. It's not just to lose weight and that's it. We need to have also a good amount of muscle in our body, and I will discuss that later. Dietary habits is a thing that we can change. Control our high blood pressure is a thing that we can change. Stop smoking or trying to cut it down is a thing that we can change. So that's what I'm trying to show in this imaging. What factors we are able to change and what factors we are not able to change. Really quick, diabetes is a big group of disease, and then again, there's different type of diabetes. Nowadays, to define the type of diabetes is getting harder and harder because we can have a mix of everything. But the big two different type of diabetes is what we call type 1 and what we call type 2. So type 1 usually was the type of diabetes that affect the teenagers, the children, that they're not producing any insulin, is an autoimmune condition. An autoimmune condition means that our own antibodies, the same antibodies that protect us from virus like COVID or flu, same antibodies, instead of protecting us, they are joining to the pancreas, that is the organ that produces insulin, and destroy all the cells that produce insulin. So that's what we call insulin deficiency, total deficiency. But we thought in the past that this is a type of diabetes that are not affecting the adults. This is a type of diabetes that affect the teenagers and the children, and that's not true anymore. We're having more and more patients on their 40s, on their 50s that develop this autoimmune condition. Why? Because it's very hard to predict an autoimmune condition. Sometimes is very, very mild, and they just need a trigger, an infection, new medication. So anything can activate this. And the most common diabetes is the type 2. That's it. That's the diabetes that we're gonna focus today, because that's the real pandemic here. Is a no is not is This is not an autoimmune condition. This is purely a metabolic condition that is associated with what we call insulin resistance. So insulin resistance means that your pancreas is producing insulin, but because of all these metabolic conditions, obesity, fatty liver, high blood pressure, high cholesterol, affect our tissues, and that insulin is not able to act on these tissues. So that's why our receptors for this insulin are very resistant to the insulin. So that's why it's not working. And at the end, if we don't do something with this, if we don't treat or manage or help with the insulin resistance, with the time, at the end, the pancreas will get exhausted, and at the end, you will have a combination of both, not just insulin resistance. You will not able to produce insulin, because we are trying and trying the insulin to be effective in our body, but nothing is helping, and at the end, you're not able to produce more insulin. So at the end, you can have both insulin resistance and insulin deficiency. If we don't treat, or if we don't do anything, uh, that's the outcome of this. So that is what is very important to prevent risk factors, to prevent the evolution of these conditions, right? Especially with the type 2. Then the other type of diabetes is diabetes related to pregnancy. That's what we call gestational diabetes, and diabetes related to other things like medications, chemicals that I'm not gonna discuss about those, because we're gonna focus on type 2. That is the most common type of diabetes. So in this picture, I just trying to show what is exactly insulin resistance. So insulin resistance means we're eating our food. There is our pancreas. Our pancreas produce insulin. So insulin comes to our system or to our cells. Then in a normal tissue or cells, we take the insulin, and then insulin helps us to take all the sugar from our body, and then that sugar then convert to energy. So we're burning that sugar, right? So, but what happened on this metabolic condition when you have insulin resistance? We are eating, pancreas produce insulin, and then that insulin is not able to affect these cells. Why? Because there is a lot of fatty cells there. There is a lot of fat tissue. There is a lot of fat mass. Whatever is the reason, our insulin is not working on those tissues. So what happened? If we don't have the insulin working on those tissues, all the sugar, all the food that we are getting, that sugar is not processed, and that sugar continue to accumulating, and they convert to fat. So yeah, sugars that are not using, they are converting to fat. So then it converts into fat, and then you can have all these problems related to metabolic conditions and diabetes. Then you can feel tired, hungry, and I will show you what symptoms you have usually with diabetes. And this is a cycle. So if you don't do anything, with time, more insulin is coming, more resistance, more weight gain, more insulin is coming, more resistance, more weight gain, and this is like a cycle that never ends. And the only way that we ended up this is with changing your lifestyle and some medications that help with insulin resistance. So what are the symptoms of diabetes in general? Of course, diabetes, type 2 diabetes, is a consequence of insulin resistance. So symptoms increase thirst. You feel that you're very thirsty, more than the usual, and you drink a lot of water. That's a thing that need to keep our attention, because okay, this is not common. And then frequent urination. You feel that you're going to the bathroom. You were going like 3-4 times, and now it's 8 times a day. That's not normal. Your appetite is increasing. so excessive hunger. So yeah, that's a kind of not a specific symptom, but if you have a combination of increase of your hunger, a lot of increase in the frequency of urination or increase the thirst, that's something. Then the headaches, blurred vision, slow healing, those are symptoms that sometimes we don't pay attention because yeah, everybody have headaches. Everybody at some point can have blurred vision, but if you have a combination of all these, something is wrong in your body, and then you need to make sure that you don't have problems with your sugars or with the diabetes. Okay. Then, so what are the screening tools? So, what would usually, if you ask me, okay, so how can I check my diabetes? And the answer is all of the way to check is with a blood work. Simple blood work that can be a fasting blood sugars, or what we call the A1C, hemoglobin A1C, that is the diabetes marker that check basically the amount of sugars that is in your red blood cells, um, or with a specific test that we usually give you sugar, like 75 grams of sugar, and then we check in 2 hours the amount of blood on your blood sugars. And the last way to check is also if you have any of these symptoms, like as I mentioned, high urination, thirst, like a lot of appetite, blurred vision, bad wound healing. With those symptoms, if we check randomly your blood sugars, like no fasting, any time, any day, and it's more than 200, that's another way to diagnose diabetes. So usually that's the way to diagnose, and usually that's also the way to test. Basically, in terms of screening, we can use either the A1C or fasting blood sugars. Any of those are easy to do. You just need to tell your primary care or your physician to check the A1C or just check a fasting blood sugars. So that's the easiest way, because the other two ways is okay, you are not waiting for your symptoms, and yeah, giving you the extra sugar to check your blood sugars after 2 hours is too much work. So it's easy to do in just one blood work, one blood draw. And then we're talking about these conditions, risk factors, diabetes, but you will hear a lot about pre-diabetes. So is pre-diabetes bad? That means that I will develop diabetes. What I need to do with pre-diabetes? But again, first we need to define what is exactly pre-diabetes. Pre-diabetes basically is a condition with still abnormal management of your sugars, probably abnormal response to insulin, but you are not a diabetic. We need to be clear, you are not a diabetic, but it doesn't mean that you can develop diabetes. As a pre-diabetic, you have a higher risk to develop diabetes compared to the general population. So that's a time that it depends totally on the way that you handle this to prevent the developing of diabetes. So that's what's very important. If you have any of these screening tests and it shows pre-diabetes, we need to work on your lifestyle changes. Some medications can help also to prevent diabetes, but it's a time that we need to be very careful with our health. Okay, but again, pre-diabetes is not diabetes, but is a higher risk to develop diabetes. So all these in this table, I'm just trying to highlight who, I mean, which patients or people or population needs to have an screening for diabetes. Again, an screening meaning like a blood draw, right? A1C or fasting blood sugars. Anybody with a BMI that is a body mass index of more than 25 in the general population and more than 23 nations, that means overweight, plus history of family history of diabetes. If you are African American or Latino, if you have history of cardiovascular condition, if you have high blood pressure, all this you need to have a screening test for diabetes. If you have history of prediabetes, you need to check your A1C or fasting blood sugars at least once a year. Don't wait like 2, 3 years. Don't wait until next year. Do it now. Um, if you have history of diabetes during pregnancy, you need to check every 1 to 3 years. So don't wait until you develop symptoms. Don't wait until you develop the condition. You need to check yourself. And this is the most important thing now. The guidelines recommend, like, to any people that are 35 or older, you need to have a screening. Before it was 45, then it was 40. Now the age is even younger and younger. Now it's 35, and everybody thinks that, oh, diabetes is a condition for older patients. That's not true, because we have younger patients with obesity, with overweight, with high blood pressure, with high cholesterol. So that's why we are decreasing the amount of age for our cutoff to check for diabetes. So in general, if you are 36, if you are 37, it's time to do a screening test for diabetes. Um, so yeah, that's basically the most important thing that I want to highlight here. So after talking about risk factors, after talking about these metabolic conditions, the definition of diabetes, the definition of prediabetes, we're gonna talk about the most important thing: how to manage this, how to manage diabetes. Again, diabetes is a chronic condition. Sadly, there is no condition that we have a cure. We manage the diabetes, we can have control, but diabetes doesn't have a cure. It's a chronic condition that will be forever. That's an important thing to understand. The same with high blood pressure, the same with high cholesterol, the same with all these chronic conditions, because people with diabetes usually have one or more other metabolic conditions. So the good thing is that, yeah, that is not good, because I don't like to take too many pills. I don't like to have too many metabolic conditions. But sometimes if we do our appropriate interventions with the appropriate medication, sometimes the same intervention in terms of lifestyle changes and medication can help with the diabetes and the other metabolic conditions. So it's like a combo management, and that's the best option, because I will talk about what is exactly the options that we have for treatment. So in these slides, I just put it all the things that we need to keep in mind to treat diabetes. The first is education, because it's very important to understand first what is diabetes. Because if you don't understand what is diabetes, if you don't understand the risk factors, you are treating something that you don't know. And that's pretty important, because even for people that are diabetic for 20, 30 years, sometimes in my clinic I ask a couple of questions, and they still don't know what that means. And that's insane, because they're like, yeah, you can tell, oh, you're being a diabetic for 20 years and you don't know this, but sadly that happens. So that's why education from the day one is one of the most important thing on the treatment. You can have the best medications, you can have the best lifestyle plan, you can have the best nutritional meals, but you need to have education of what you're having in your body, of what condition it is, what is exactly what you have. Then we need to work on your prevention of the risk factors that we talk about. Nutrition therapy. When I say nutrition therapy, I don't like to use the word diet, because when we put diet in our mind, we think that is something very restrictive. And as a human being, when they restrict everything to us, we want more and more and more. So that's why I like to call this like a healthy way to eat, a healthy food, healthier way to eat. That's it. Because I have patients that they're been on with diabetes for many years, and when they hear the word diet, they say, "Oh my God, I will not able to eat anything. I just gonna eat like veggies and chicken without salt, and that tastes awful." And I agree with that, because yeah, it tastes awful if you don't combine different healthy options. So yeah, diet is a term that we need to be careful, because that can cause a problem with some patients. And then physical activity, that's another thing that we're going to talk about. What is exactly physical activity? What is a realistic physical activity compared of what people think that I'm going to tell to them? Again, I'm not planning to tell you, okay, you're going to run 2 miles every day, then you're going to do more cardio, then you're going to do weights, and then you finish your week with yoga. So that's impossible. Nobody, even the doctors, they don't do this. So yeah, we need to be realistic on what we're planning to do with the patients. Psychological intervention, of course, this is a condition because it's for life. Sometimes you have a lot of frustration. That's part of the journey. Sadly, that's part of the journey. Frustration, and then that can cause depression, anxiety, poor sleeping. So we need to work on that. We don't need to we don't need to ignore this psychological intervention. And finally, I put just like the straight glycemic management, that is basically insulin. That I'm not gonna discuss the details of the insulin, but I'm gonna discuss what is a good tools when somebody's on insulin. So education, the first thing, we have our diabetes self-management education program in our clinic with our diabetes educators and also here. So it's important to have self-management classes to understand how to manage, to understand the disease, to understand how to manage your disease, to understand the diabetes process, how is the evolution of the condition, to learn how to take your medication, because sometimes it looks easy, but no, it requires an effort. It requires to be constant on that. So yeah, it's hard. Make healthy eating choices and realistic physical activity. So in a typical session is helping to understand how diabetes affect your body. That's the first thing. Uh, Explain how the diabetes medication works, because you have like 6, 7 different family of medications. Every medication has a pros and cons. Every medication has a benefit and also a side effect. So patients need to understand what are the side effects of the medication, what are the benefit of what exactly I'm taking. Because if I develop a side effect, I need to know that probably it's because of this medication. And before stopping right away and affect my diabetes, I can discuss this with my doctor. So, Dr. Campagna, you discuss this with me about the side effects. This medication is causing me that side effects. What we can do? That's the best way, instead of just stop the medication and that's it, because that happens. Some people develop side effects. They stop the medication. They never have this conversation with their physicians, and at the end, the diabetes start to worsen and worsen and worsen. So yeah, that's why it's important to understand the medication and keep a good communication with your physicians. Planning the best food and meals for your budget, for your preference. That's important also. That's what we need. It's very important to have a dietitian with us, a nutritionist. And again, we're here, all the team, endocrinologists, primary cares, cardiologists, nurses, diabetes educators, all the multidisciplinary team that are working for you. They need to give you tips to cope with this, with the stress, with the frustration of the disease, right? Of course, that part of explain how diabetes is treated and discuss the prevention. Prevention is the most important. Prevent long-term effects of the complications or prevent complications. So that's very important. In terms of the nutrition, yeah, it's just part of the treatment. It's a coadjuvant therapy. Our goal with nutrition is to reach a certain amount of weight loss that if you see it looks a lot, but with all these lifestyle intervention, you will notice that you can lose weight, and not just losing weight, also building muscle. That is part of the physical activity. That's why nutrition alone is nothing if we are not put it together with physical activity. So use usually nutrition and physical activity. If you can get a weight loss like 5 to 10% of your body weight, just with that, you can improve your blood pressure, you can improve your sleep apnea, you can improve your fatty liver, and you can improve the insulin resistance just with that. If you put that also with exercise, then of course you will improve your diabetes. So that's what is important. Um, Again, for nutrition, there is no perfect plan. I can talk about like all the plans and diets. We can be here. We can discuss that for like 3 4 hours. But at the end, is what is best for you. Is what the best for your patients. What the best for your family member in terms of what he or she likes. What we can offer that is healthy, but also enjoyable, because again, the word diet cause a lot of issues of, oh my god, all the things that I'm gonna eat is gonna taste really bad. So yeah, I put like a long list of uh, types of diet. We have hypocaloric, low carb diet, ketogenic diet, this combination of hypocaloric plus lifestyle that is one of the most famous trials of the look ahead studies that shows that yeah, that's the best option, and Mediterranean diet. At the end, I will give you the two diets or type of interventions that helps. That is the hypocaloric, meaning that you reduce the amount of calories, but it doesn't mean that you are just putting uh, food with no good taste, without salt or without anything. Yeah, again, I'm a believer of that. If you are doing this intervention, at least you need to have your cheat day to enjoy whatever you like to eat. And the Mediterranean diet, that is one of the diets that you don't require calorie restriction, is equivalent weight loss to the hypocaloric. So I'm a big fan of the Mediterranean diet because it's not that much restrictive as the hypocaloric. Physical activity. So the guidelines recommend 150 minutes of moderate intensity physical activity during the week. That you can divide that based on your time, based on what exactly you can do. So moderate intense physical activity, that can be walking, like brisk walking, biking. So that doesn't mean that you need to run, that you need to go to the treadmill. Is any of the of aerobic exercise, like cardio, any type of cardio. Usually, I tell my patients if they like any sports. I have patients that like soccer, tennis, basketball, whatever sport that you like. Put that on your physical activity, because in my case, I'm a tennis player, and if somebody tell me at 7 a.m. on a Saturday, let's go to the gym, there is no way I will go to the gym at that time. It's too early for me. But if somebody tell me, let's go and play tennis at 7 a.m. on a Saturday, I would be there at 6 a.m. because that's what I like. That's why I love. So always trying to find this, what you like to do as a physical activity, because that's very important. That then you will feel that you're enjoying your changing lifestyle. Because my goal is not to give all this lifestyle plan, so you will hate it and you will be miserable with all these changes. So you need to enjoy these interventions. And the thing is, the most important thing of this is that it's important to combine them. You can have your aerobic exercise, but it's important resistant exercise to include in your plan. That means to build muscle. And then that's the second part of this, how we can build muscle. Everybody thinks that is just with weightlifting, and that's not true. I will say that this part of the physical activity, the resistance training, I think this is the most important part for the elderly population, because in the elderly population we have the problem of sarcopenia. What is sarcopenia? Is basically losing the amount of muscles in your body. So your muscle mass or lean mass, you start losing it with age, more, more, and more and more. And if you don't gain more muscle, at the end that will be a problem, because you will you will lose proteins, you will have a lot of nutrition issues. So sarcopenia is an important condition that we don't need to ignore for people with diabetes, especially the elderly population. So what is the type of physical activity? The resistance training that I like, elastic bands exercise. What I love it because it's practical. You can do it anytime, anywhere. It can be the night of Christmas. Okay, let's do 15 minutes of elastic bands for my shoulders, for my arms, for my legs, and you're gaining muscle. Maybe it's not the best exercise to lose weight, but it's the best exercise to gain muscle and burn fat. And especially the good option for our elderly population because you don't need to run. You will not you will not feel exhausted. You will feel how the strain in your system is going. So that's why I'm a very big fan of elastic band exercise, and I recommend this exercise to anybody, like 40-year-old, 50-year-old, 80-year-old patients. So yeah, it's a good intervention as a physical activity. And then pick your aerobic exercise. Walking is good. If you can walk, do brisk walk, continue walking, but always trying to add these type of exercise to gain muscle. Gain muscle is very important here. This is just a picture of showing all the different exercise from the resistance bands. And again, you can find everything on YouTube. You can now that everybody's using TikTok, you can find this in TikTok. So all the routines, you can find it, and for any age. So yeah, you just need to get these bands. It's like, I think it's 20 or $15 on Amazon, or you can buy it anywhere. And again, you can do this anywhere, and it's very, very useful to gain muscle. So medical management. I think that's the last part. Yeah, I think we still have good time. So what I'm trying to show here is that, again, we're not just treating diabetes. We're treating diabetes with the other metabolic conditions that are involved with diabetes or complications that they already develop with diabetes. So that's why you can manage diabetes in patients with chronic kidney disease, diabetes in patients with obesity, diabetes in patients with history of heart conditions, diabetes that have severe insulin resistance, that they are already on insulin and they're just giving more and more and more and more insulin, and that's not the plan. The plan is to give options to reduce this. We have patients with diabetes and multiple insulin injections that they are totally tired to be on 4 or 5 injections, and they're trying to find another solution. We have diabetes with fatty liver or muscle D, or people with diabetes that are more prone to develop low blood sugars, that is hypoglycemia. So that's why I put diabetes plus, all these conditions. So that's why the new algorithm for diabetes management from the American Diabetes Association is we are treating diabetes, but we need to see what type of diabetic we have. We have a patient with diabetes with heart failure. So this is the medication, the Jardians, Farxiga, SGLT2s. We have patients with diabetes and chronic kidney conditions. So this is the medication. Then Ozempic, that is a GLP-1, or Jardians, and the rest of the medication. We have patients with diabetes and history of strokes or heart attacks in the past. So for this patient, this is the medication. So again, we are treating diabetes based on what type of patients we are having, not just for the diabetes. We have patients with diabetes with fatty liver. So this is the option, the 3 or 2 medications that helps just for the fatty liver. So that's why we need to like customize our treatment for our patients. And then this is the classic oral agents. We have metformin that still is a good option. We have these SGLT2 inhibitors, that is Jardians, Farxiga, that you will watch or hear on the TV commercials. We have the famous GLP-1s, that is Ozempic, Mounjaro, and all of them in this table that is huge. And I'm just trying to summarize as much as I can, is the potential effects on weight, the potential effects on cardiovascular benefits, if that affects the sugar that much. So that's why you need to have the time to discuss with your endocrinologist, primary care, whoever is managing your diabetes about this medication. So this medication will give me this benefit and will give me this side effect. And this is at the end, the benefits and the risk and why I'm taking this. So you need to know this. You need to know your medication and how the medications are working on you, because that helps. That helps. That helps the patient. That helps the family members. So that's why it's very important, and that's part of the education. And then we have the other family of medications. Okay. If you're a patient with diabetes that you're already on insulin, I think I will keep simple and tell you this. You need to be on a continuous glucose monitoring, or CGM. This is a device that you put it on your arm, and then we can have access to your blood sugars 24/7. All patients, especially elderly population, we need to be very careful for hypoglycemia or low blood sugars. If you see in the report here, the goal for patients or younger patients with type 2 or type 1 is to keep your diabetes control or your blood sugars control more than 70%, and having less than 4% on your low blood sugars. In elderly population or older patients, we're trying to keep control more than 50%, but your lows need to be less than 1%. So the lows are more important than the highs, because low blood sugars can cause falls with fractures, brain damage, and also exacerbate some of the mental conditions like that, dementia and all that stuff. So that's why we need to be careful with the low blood sugars in our elderly population. So that's one is very important. All the patients that have type 2 diabetes that are on insulin, all of them needs to be on this device, continuous glucose monitoring, or CGM. So as your primary care, as your endocrinologist, to use this. And again, you're using a device and you need teaching for this. So again, you need to have the time, or your provider needs to give you the time to give help with teaching by diabetes educator, the nurses, whoever is available, to teach you how to use this, what to expect about this, what is exactly this working on my body. But this is a very important tool for people that are on insulin. This slide is just showing how we calculate the insulin, how you will give it pre-lunch, pre-dinner, breakfast. So I'm not gonna go into detail of the calculation. I just want to highlight the importance of the continuous glucose monitoring, or CGM. You need to be on this if you're on insulin. And then I think this is we're almost finishing with this. The prevention of the complications and the comorbidities. So yeah, all the studies, the diabetes prevention program, how to prevent this started with screening tests. I already show which patients need to be on this screening for diabetes or pre-diabetes. Lifestyle changes, the importance of muscle gain, as we discussed. If you're already a diabetic, you need to have your eye referral or eye check every year. We need to assess for neuropathy with a monofilament test in our office to check how is the sensation of the foot. And also you need to follow with a podiatrist or a feed doctor every year. We need to check the urine, the amount of protein in the urine, to make sure that your kidney is good, because these three things, the nerves, the kidneys, the eyes, are some of the organs that can be complicated with the diabetes. We need to prevent any cardiovascular event, strokes or heart attacks. We need to optimize your cholesterol. We need to optimize your blood pressure. And most importantly, we need to also check your bone health. So usually people with diabetes have more predisposition to develop osteoporosis. So all the patients females or males older than 65 needs to have a bone density scan. All people with diabetes older than 65 needs to have a bone density scan and check how is your bones, because a lot of providers check all these cardiovascular prevention complications, but they forget about the bone health, and bone health is also important. Screening for fatty liver. When we are checking your blood work, we can calculate the risk of developing fatty liver, because fatty liver is the number one cause of cirrhosis. It's not like drinking as before. This is a real thing. And to finalize, I will give you 5 ideas to reduce sugar in your diet. So first, check always the nutrition facts or labels. If you see, you can check then the amount of carbohydrates, and then you will see, okay, if this product have like 21 grams of carbohydrate, that basically is the problem that can increase your blood sugars, and I have a product of 45. So of course you're trying to pick the product that have the least carbohydrate amount. So always check or read the food labels carefully all the time when you're going to for your groceries. Yeah, to be honest with you, I don't like water. I hate plain water. So I totally understand patients with diabetes that they want something, and then yeah, we can tell them, okay, drink diet soda. But still, new study shows that aspartame is another problem. So patients are getting frustrated. Okay, so on the other side, my diabetes is not good, and now the new study shows that aspartame is good. So what I supposed to drink? I hate water. So one option is to do these fresh herbs and fruit flavored water, and it's natural. So you can have sparkling water with a strawberry mint, or you can put some lemon there. You can put some orange there. Still, if you ask me, but these fruits also have sugar, right? Yeah, but the amount of sugar is minimum compared with a regular soda. And again, if you're concerned of the aspartame on these diet sodas, this is a natural way to have a flavored water, and you will able to drink. Because again, as a physician, I'm trying to be honest with the patient. So I'm not gonna ask you things that I'm not able to do it either. I don't like water. I hate plain water. So I think it's a very good idea to give some flavor, natural flavor to your water. So in that case, with this sparkling strawberry mint water, uh, you're not concerned of the aspartame. You're not concerned of the sugar drinks. Snack smart. So we have hummus, we have veggies, carrots. A good option is nuts, seeds, or dried fruit. That helps as a healthy snack between meals, because that is very helpful to work with your cravings. All of us, everybody have cravings. In my case, I have cravings for pizza. I love pizza. I can I can eat like an entire pizza, but if I get these snacks, nuts, seeds, or dry fruit, I still can have my pizza, but my appetite will be reduced. So instead of the whole pizza, I can just eat like three or two slices, and that change means a lot, because the amount of carbs, the amount of calories of the entire pizza is way more than just three slices. So that's why this is also a realistic way to prevent these increments in sugars with food from food. This is just a general picture of how should be your diabetes plate. Trying to put a little more veggies. I'm not saying don't eat carbs. We need carbs. Our brain needs carbs, but the portion we can reduce it. If our carbs was like 50 or 60% of our plate, now it will be like a 30%, and the rest of 70% will be protein and vegetables. And finally, we have new sweeteners. I like the monk fruit. It's more natural than stevia. I usually use that because, again, aspartame, saccharin, we're having studies that shows it's not that good for our health, but monk fruit and stevia, it's a good option. And I think that's it for you. That's what I have, and I want to share with you that we need to remember that diabetes isn't a sprint; it's a marathon, and we are your doctors, your providers were here for the long run. Thank you so much for your time, and I'm opening for questions now.
Awesome. Thank you so much for the thorough
I heard,
presentation and for explaining all the factors and the aspects involved in this disease, which you call the real pandemic. Let's start by opening the floor to our colors. I think somebody came off mute already. For
yeah.
all the other
I
colors, know that, remember, it's *6 to unmute. So thank you. Your question.
Okay, I heard him say the milligrams for carbs, but I missed him talking about the sugar. How high should the sugar level be if
The
we are
sugar,
avoiding sugar
you mean the sugar level of how
in
much
any
after?
any drink? Yeah,
Oh yeah. So if
because
you see, yeah.
sometimes we see labels that say sugar is 6%, but added sugar is 12. So I'm trying to figure out where that should be.
I got it. So yeah, again, you can find different products, but I will say that you need to check the added sugar, because sometimes the sugar that comes in the product still is kind of similar to the amount of carbs. So what I recommend is try to find as low as you can of added sugar. So it's not a magic number, but I will say if you have a product, for example, cereal, right? You have cereal
Yeah.
and granola. In your cereal,
Okay.
if you find 35 grams of carbs and then 10 grams of added sugar, and then on the other side you have the granola that is 40 grams and just 3 grams of added sugar, go for the granola. Okay. So
Okay.
I will say that try to find options with the less added sugar that you can, because it's hard to give you a magic number of, oh, just less than 10, less than 12, because yeah, it's hard. At the beginning, go by your amount of carbs and the less amount
Mhm.
of added sugar.
Sugar. Okay. Thank you.
No problem.
Good question. I immediately went to my pantry and grabbed my peanut butter. I'm like, wait, peanut butter. So I think we're okay. Okay, anybody else? Any of our colors would like to unmute before we proceed to all the other questions from our YouTube
I
viewers?
have a question.
Go ahead.
What's what's a normal A1C? What should we aim for, diabetic? What should a diabetic aim for on that A1C?
So in A1C, if you're a diabetic, a control A1C, because we don't want to aim normal, because if we aim normal to people with diabetes, probably you will have low blood sugars. What we call controlled diabetes is an A1C less than 7. Okay, that's a controlled A1C or controlled diabetes. If you are not a diabetic, a normal A1C is less than 5.6. If you're a pre-diabetic, that's the time that we're trying to aim a normal A1C, because pre-diabetic are from 5.6 to 6.4. So if you are of 5.8, then we're trying to aim less than 5.6. But if you are a diabetic, a good A1C or a control A1C is less than 7.
Thank you.
No problem.
Another similar question is around that. The A1C, it says to be greater or equal to 6.5, but the test is done fasting. What if done fasting, somebody that has no diabetes or pre-diabetes diagnosis,
Mm-hmm.
if the result is then close to 6.5, let's say 5,
Mm-hmm.
is that when the sugar and waiting 2 hours, when is that recommended or no?
So if you check your blood work, right, and then check the A1C, and your A1C is 6.2, that means that you are on the pre-diabetes range. So we don't need to do the 2 hour loading test with sugars, because we know that you're a pre-diabetic. So in that case, then we need to focus on trying to bring that A1C down with lifestyle or medication. One of medication that we use for pre-diabetes is metformin, the same that we use for diabetes, but that's the only one that we use for pre-diabetes. But if your A1C, because A1C and fasting blood sugars are a different test. Sometimes you test you test both, and if the A1C is more than 5.6, you are on the, but less than 6.4, you are on the pre-diabetes range. That means that your fasting blood sugars can be 110, 112, that you're still categorized as a pre-diabetic.
So if it's 5.5, they're still good.
Yeah, you're still
Okay.
you're still in a good range. Yeah.
Any other color? I think I see someone on mute that is unmuted. I don't know if that was a previous one.
Yes.
Go ahead. Maybe it was the previous caller. Okay, the question is regarding the continuous glucose monitoring, the CGM.
Yeah.
How often is that replaced, or how does it work?
Very good question. So this is a sensor, like a tiny sensor that you usually put it under the arm, like here. Okay. That check the interstitial sugar, not like the same that you're checking here in your fingers. And the good thing is that we can check your blood sugars all the time, so you don't need to prick your finger anymore. Depends on the brand. We have 2 different brands that we use, the Dexcom G7 or the Libre 3 Plus. So the Libre lasts for 15 days. So after 15 days, you need to replace it. And the Dexcom G7 lasts for 10 days. So after 10 days, you need to replace it. But you can connect this sensor either to your phone or to a reader that we can provide the reader, whatever you prefer. So I have patients that they use their phone all the time. So for those patients, I prefer to be on the phone. For my elderly patients, like people on the 80s, 70s, sometimes they don't use that much the phone as we use. So for those, I gave you the reader, because I think that they will be more compliant taking the reader with them than the phone. So yeah, but you can connect this either to the reader and the phone, and then when you go to our clinic or any clinic, then we can download it, your blood sugars, and then we can check all the trend of your blood sugars for the last 2 to 3 weeks.
That's fantastic. Very person-centered, whatever the person is comfortable with and their confidence. Excellent, excellent. One question about GLP-1s. Are they resulting in osteoporosis or bone loss?
No. So the GLP-1s that now is one of the most common and popular medications that we're using, they don't cause bone loss or osteoporosis. Diabetes per se cause osteoporosis and bone loss. The most common side effects of the GLP-1s are related to gastrointestinal side effects. Some people have bloating, constipation, mild nausea, but it varies. It depends on the dose. I usually start with the lower dose to see how the patient responds, and then I start to titrate up after 4 weeks. And I have patients that with the small dose, they don't have any side effects. I have patients that they have some side effects that we can give some measurements to decrease the side effects. But at the end, it's a very good option for weight loss and managing diabetes.
Okay, 2 more points before we wrap up, if you still have the time.
Yeah.
Okay, good. The connection with sleep, we do know that is restorative and that is needed for so many things, but that correlation with diabetes, why is sleep so important and how is the mechanism?
So the mechanism, because when you are not sleeping enough hours, because remember that during sleep time doesn't mean that our brain is not working. Actually, when we have this deep deepest stage of sleeping, you're still burning calories, right?
Mm.
So if you don't have this amount of burning calories, people that are sleeping like 3-4 hours a day, they are not
Oh,
burning this amount of calories, so they have more predisposition to have weight gain, and that weight gain can cause more insulin resistance, and then insulin resistance can increase the risk of diabetes. So the correlation is basically related to the metabolic change of poor sleeping. And again, it's kind of confusing because some of these patients that are not having poor sleeping also have a sleep apnea. That is another condition that have predisposition to diabetes. So that's why if we are thinking that just the poor sleeping can cause diabetes, we don't know, but poor sleeping can increase your weight, and that can increase your diabetes. So that's why the results are still confusing, but still not sleeping enough hours. What we know for sure is that can increase your weight. So sleeping is
interesting.
very important. It's not just for the
Yes.
kids. It's not just for the children that,
Yes.
as a child, our mom always said, you need to sleep, go to sleep because you need to grow. But yeah, still in your adult
You're
life, you
right.
need to sleep. You need to
Mm-hmm.
sleep well.
Mm-hmm. Well, thank you so much. We greatly appreciate also this you speaking about prevention even in the face of having received a diagnosis, rather diabetes or pre-diabetes, about
Mm-hmm.
things that still can be done to prevent complications. And also you talked about the physical activity, the minimum of 150 minutes a week, and making that connection to what is it that doing something that, like you said, that you love, that you like, something that you really enjoy. Um, and just so you know, everyone, also we offer some of the programs through Rush Generations. We offer Fit and Strong, Tai Chi, bingo
That's
sites,
nice.
fun activities that people can engage in and that will help them remain physically active. The same way of the diabetes self-management programs that we offer, in which people can learn to do the reading labels, reading the nutritions in the
That's nice.
labels, learning about the plate methods and all of that. So maybe we can also connect in terms of uh, sending patients to our programs, because people have found them very, very helpful. Um, I'm also interested in how is it if people, when you're doing that education piece or presenting the information, I'm always interested in knowing, do people, can even people see their future self? Can they think about in 20, 30, 40 years, eh, can I still say I want to do all these things?
Mm-hmm.
Or after a diagnosis, it's like, the depression sinks in, or
So yeah, I mean, I I think I always try to be as much honest as I can with the patients, because I think me as a physician that I don't have diabetes. The worst thing that you can tell a patient is, "Oh, I understand. I understand that it's hard for you. You don't understand at all. You are not
Mhm.
dealing with injections. You are not dealing with the fear of I have this forever. You are not dealing with, oh, I need to change my lifestyle because of this." So I think the during the first time that I have my patients that for the first time are diagnosed with diabetes. So the first, to be honest, 6 months are tough. Are tough to understand that this is forever. But
Yeah.
at the end, if you are there for them, as a because we are more than the doctors. I'm like a coach, and as a coach, you
Mhm.
can also sometimes have problems, and you can also have frustration for some patients that you feel that they are not engaged in the disease. But that's normal. That's part of the journey. But then after time, after see the first results, tiny results, you always need to have this positive reinforcement. And after that, they slowly putting on track. And then I always tell them, it doesn't matter the age. I am a long-term planner doctor. I'm not seeing yourself in the next month. I'm seeing yourself in the next 10 years. I see yourself enjoying with your grandkids, like with a good leg, with a good eyes, with not no any heart attacks. I don't want you to have a heart attack in the next 20 years to have a good life. So I think sometimes that is the stimulation that
Yes.
they need to deal with this. Yeah.
Wonderful, wonderful. Well, Dr. Campaña, it was a true pleasure and honor to have you here. Thank you so much. Please keep any other questions that you can think of. Feel free, people, to put it in the chat and we can get it to you later. Or
Sure.
feel free to always call our toll-free number if you would like more information about Dr. Campaña's clinic and the services offered here at Rush.
Thank you so much. Thank you so much for your time. And I always enjoy to give these lectures to patients.
Oh, wonderful, wonderful. Thank you. Very person-centered as well, which we like. Absolutely. Okay,
Thank you so much.
everyone. Thank you. Thank you. So we are going now to let you know about upcoming programs that we have through Rush Generations. And one of the first programs that we have coming up is for those individuals that are dealing with chronic pain. The Learning to Live Well with Chronic Pain is a free 6-week workshop for people that are living with chronic pain, but that helps place, this one takes place over the phone. It's a telephone toolkit, what we call it. The group engages participants in discussions and skill building activities to better cope with the day-to-day management of chronic pain, so that you can do more of what matters to you. So the sessions include wellness action planning, problem solving, exercise or physical activity, as Dr. Campaña said, nutrition, strategies for medication management, pacing activity and rest, communication with family, friends, health professionals. So if you are dealing with chronic pain and would like to give this telephonic toolkit a try, feel free to give us a call at our 1-800-757-0202. The workshop is going to be held on Mondays from 10 a.m. to 11 a.m. Again, over the phone, and it's coming up. So please give us a call. We are also offering pretty soon a Matter of Balance, which is an 8-week session workshop for individuals who have begun restricting their physical or social activities because they've developed a fear of falling after a fall. The workshop utilizes problem solving, confidence building, and balance, improving exercise, and cognitive restructuring to help participants prevent falls, as well as improve their balance, regain the ability to do what is most important to them. The next workshop will be held in person at the main campus, and the Rush campus on Tuesdays and Thursdays. Is 2 hours from 1 to 3 p.m. And the workshop is going to run from November 11th through December 9th. So again, 1-800-757-0202 if you would like more information or you're ready to register. Shalman Senior Voices wants to hear from you, wants to learn from you. We aim to empower older adults to discuss what matters most to them as you age. It is important to share what matters most to you with your physician and your loved ones. And Shalman Senior Voices give you that opportunity. So please consider sharing your wisdom on why it is important for your healthcare teams and your loved ones to know your goals and your wishes and what matters most to you. Feel free to scan the QR code and then recording a video on a mobile device or a smartphone. Okay, and then our next lecture this month is Caregivers Month. So we are going to have two of our colleagues from Rush Social Work and Community Health Department speak to us about caregiving. The lecture is titled Caregiving 101. It's in 2 weeks, November 19, again at 1 p.m., and we hope to see you there. And as always, feel free to give us a call if you're in need of resources or speaking with a social worker, more information about our programs. That's the same number for all of that, 1-800-757-0202. We'll see you next time. Thanks.